Hello. Good afternoon. Thank you all for joining us. Thank you for the Hardy that have stood with us since the beginning. Thanks for you that made the time to join us now. We now have a wonderful session in front of us that's called Ensuring Health Equity in Lung Cancer Screening and Management. It's co-moderated by Garth Graham and Christopher Latham. I'm going to try to minimize my comments so I allow you to have maximal time. And please introduce yourselves as you see fit with the speakers. But you know, I just got to take advantage of this opportunity to acknowledge an incredible gesture for one of our leaders for this upcoming panel, and that is specifically Dr. Garth Graham was elected to the National Academy of Medicine yesterday, and that's a wonderful life accomplishment, profoundly important body doing wonderful things, and you know, it's just congratulations. And that being said, Chris, I'm not sure if you or Garth want to get going, but we're looking forward to your comments.
Thank you very much, James. I know I was giving a little space there for you know, just to bask in a moment there for Garth. That's fantastic. It's really just a great honor. I'm Chris Latham. I'm a medical oncologist at Dana-Farber Cancer Institute, and welcome everyone to our session 3, where we're going to be discussing health equity and lung cancer screening. So, you know, many of us, we've been in this space for a long time, and I really would like to thank the organizers. I want to specifically, thank Jim and Carolyn really for putting a lot of this together and bringing all of these like-minded folks together. We really have a great set of panelists, and I'm gonna let my co-moderator, I'm one of the moderators, and my co-moderator, Garth Graham, I'll let him introduce himself as well. As you heard, he's had a good day already. And then what we're really planning to do in this, the other panel members who will be involved in, you know, you're gonna hear from topics, Dr. Mary Pasquinelli is gonna actually give a talk as well. And our other panelists, Dr. Pettit, from the Cancer Care Institute at Monument Health is going to also give us some information on what he's doing. But what we're trying to do today is we're gonna open up with a little didactics, and then we're going to go right into continue this kind of question answer discussion format that you've seen. And I think there'll be opportunities for us to monitor the Q&A sessions and get to all of your questions as well. But we're really looking forward to it. I don't know if Garth, if you wanted to say hello and good morning as well before we.
Well, I more want to say it's an honor to be with Chris. I mean, those of you know Chris's background, track record, and passion in this field, and everything that goes along with it. I think goes without saying. So just honored to kind of be his wingman as we kind of move through this next 2 hours.
Thank you very much. I think, again, our plan is really to break this into 2 halves. And so in the beginning, kind of the first half, thinking about health equity and vulnerable communities, and, starting first with a talk from Mary Pasquinelli. And she actually had worked with a mentor of mine, Robert Wynn, for a while too. And I am always been very interested in exactly what the work that she's been doing in the federally qualified health center space. And you're going to hear from her from the University of Illinois Hospital. And again, we'll start with that. And then afterwards, the rest of our panelists, Dr. Pettit he's done a lot of work in the American Indian, healthcare disparity program. And he's also going to intersperse and talk a little bit about some of the challenges and things that he's seen in his space. But we're going to start first with an overview and kind of tone setting from Mary. So Mary, why don't we get you to go ahead and get started and take it away.
Great. Can you see my slides okay?
Yes.
Perfect. So I'm Mary Pasquinelli. I'm a nurse practitioner at the University of Illinois in Chicago, and I'm going to talk today about race and gender disparities in lung cancer screening. I do not have any disclosures. And at UI Health, University of Chicago, which is also known as UI Health, I wear a lot of hats. I started the lung cancer screening program in 2015. I have a dedicated pulmonary nodule clinic for incidental and screen detected nodules, where I work with my patients to understand their individual risk of lung cancer and how we can modify that risk. And then I see patients in the lung cancer clinic. So essentially I see patients from screening through lung cancer diagnosis, through their treatment, and hopefully onto survivorship. And at UI Health, we are working to decrease disparities and overcome barriers in care to improve health outcomes. And because of my perspective of seeing patients from screening through diagnosis, it was very evident that there was a race disparity when it comes to lung cancer screening. So this talk is a little bit more about that. So our latest work builds on our past study that was published in JAMA Oncology in 2018, where we compared our lung cancer screened cohort compared to the National Lung Screening Trial. And at the University of Illinois at Chicago, our first 500 patients were screened, and we compared this to the National Lung Screening Trial. And our cohort consisted of 70% African Americans and 73% current smokers, which is very different from the National Lung Screening Trial that had 4.5% African Americans and more were likely to be a former smoker. We also found 2.5 times more diagnosed cancers compared to the National Lung Screening Trial. And even though our program is much more robust now, we're staying at that 2.5 to 2.6% diagnosed rate in this very high risk population, because we know that African Americans have the highest incidence and mortality from lung cancer, even though they tend to smoke less compared to white smokers. So I want to introduce you to our current work. We are calling this the CREST study, which stands for the Chicago Race Gender Eligibility for Screening Cohort, or the CREST study. What we wanted to do after our last study of looking at the screened population, we wanted to be able to screen high-risk individuals that did not meet criteria, but if they do not meet the USPSTF or CMS criteria, the screens are not paid for, so we could not really look at that cohort. So what we did is we developed a new cohort, the CREST study, and I show this picture, kind of one of my favorite prints, a Japanese block print of the great crest of the Great Wave, which hangs in the Art Institute, one of my favorite pieces of art. So what the CREST study is we did a retrospective study of diagnosed cases of lung cancer cases that were diagnosed at the University of Chicago between 2010 to 2019. And they had to be current or former smokers. And the University of Illinois at Chicago is an academic hospital that serves primarily a minority population from low socioeconomic communities on the south and west side of Chicago. There are 883 cases that met our inclusion eligibility. And the aim was to compare the USPSTF criteria to the PLCO 2012 risk prediction model for sensitivity and the ability to remove disparities in lung cancer screening eligibility criteria. So for those who are not familiar with the PLCO risk prediction model, it's a validated tool that shows the 6-year risk of lung cancer, and it has more than just age and smoking variables. It has 11 variables, all which are related to increasing your risk of lung cancer. What is important is there is not a limit to age, smoking pack years, or quit time within the PLCO 2012 risk prediction model. So our latest research was recently published in the Journal of Thoracic Oncology in August of this year, called Risk Prediction Model versus the USPSTF Lung Cancer Screening Eligibility Criteria, Reducing Race Disparities. Before I talk to you about the results of that study, I wanted to discuss our population characteristics of the 883 diagnosed lung cancer cases in these last 9 years. They consisted of 56% African Americans and 29% white individuals. And you can see in the red boxes that are highlighted, African Americans compared to the white individuals in this cohort, African Americans had a lower pack year history, lighter smoking history, but they were also more likely to be a current smoker. And this is what we found. This is a table of the sensitivity comparing the current USPSTF 2013 criteria to the PLCO at a 1.7% risk threshold. And you can see in the box to the left here that the USPSTF underselects for African Americans. It selected for 62% white individuals and 50% African American individuals. And on the box to the right, you can see the PLCO was much more sensitive in diagnosing or identifying high-risk African-American individuals. It had an increased sensitivity of 21%, and that had a statistical significant p-value. So in July of this year, the USPSTF came out with their proposed draft recommendations for lung cancer screening. They decreased the age to 50 and the PAC years to 20, and they kept the quit year at 15 for former smokers. The task force knows that there is a race disparity in the current guidelines, but this is something concerning that they wrote in their recommendation. They said screening for lung cancer in persons with lighter smoking histories and at an earlier age may also help partially ameliorate racial disparities in screening eligibility. Now, do you really want to just partially eliminate disparities? No, what we want is public policy that is fair and equitable. So what we did is once we found out the new proposed guidelines from the task force, we did a whole reanalysis of our CREST study to see if the new guidelines still had a race and a gender disparity, because we'd also know that women are at higher risk for lung cancer, even though they smoke less, and they also, compared to men, and they also are diagnosed at an earlier age. So before I talk about our reanalysis, I did want to highlight the reason why we chose the two thresholds for the PLCO model. When we compared the PLCO 2012 risk model to the current USPSTF 2013 criteria, we used a risk cutoff of 1.7% or more. And comparing it to the proposed guidelines, we used a risk cutoff of 1% or more. And the reason why these risk thresholds were chosen is they were identified as a threshold that selects for a similar number of eligible individuals compared to the Task Force 2013 and the proposed 2012 draft guidelines, respectively. So first, let's talk about race disparities and comparing on our reanalysis of the CREST study. So this chart shows the sensitivity of the two criteria, the USPSTF 2020 draft criteria versus the PLCO. And you can see in the box highlighted in red that the USPSTF 2020 criteria, decreasing the age to 50 and PAC years to 20, or decrease age 50 and PAC years to 20, continues to underselect for African Americans. They selected for 75% white individuals and 71% African American individuals. And the PLCO was much more sensitive in selecting African Americans. It also had increased sensitivity in selecting whites and for the overall cohort. And that can be reflected by the odds ratio in the statistically significant p-value. So this chart shows the number and proportion of individuals that would not have met the 2020 task force criteria because of they did not meet the eligibility rules of having less than 20 PAC years, greater than 15 years quit for former smokers, and they were under the age of 50. And highlighted in the red box, you can see when we look at individuals that did not meet the 20-year PAC year, there still is a disparity between African American and white individuals. 19.3% of African Americans did not meet this criteria versus 10.5% white individuals. The brackets below these proportions shows the percent that the PLCO would have additionally picked up. So the PLCO would have identified another 31% of high-risk African Americans and 22.5% white individuals. There was no difference in race between African Americans and whites in the quit time and in years under 50 although the PLCO 2012 risk prediction model was much more sensitive, identifying those high-risk individuals also. So let's look at sex disparities in lung cancer screening, looking at our CREST study. And as I said, women are at a higher rate of lung cancer, even though they smoke less and they are diagnosed earlier. So this is the comparison of the sensitivity of eligibility criteria stratified between men and women. And the red boxes show the USPSTF 2013 and 2020 criteria. Let's look at the top box. The current criteria underselects for women. They selected for 47% women and 70 or 57% men. So they underselected for women. And this continues, the 2020 guidelines continues to underselect for women. The 2020 criteria in our cohort would have selected 64.6% women and 71.88% men. And this is statistically significant. So the new guidelines will continue to underselect for women. When we look at the PLCO 2012 risk model, at the different risks comparing 2013, the current guidelines, and the 2020 guidelines, you will see that the PLCO risk prediction model equally selects for men and women, and that is shown by the non-statistically significant p-value. So in conclusions, the proposed Task Force 2020 criteria still shows a race and gender disparity. The use of the PLCO risk prediction model appears to eliminate race disparities and minimize gender disparities. And we recommend using the PLCO risk prediction model in addition to the USPSTF 2020 guidelines. So if they do not meet screening criteria based off of age or smoking history, you can see if they're high risk under the risk model, and if they are deemed to be high risk, they should be screened. And this is a similar recommendation that was just released by the American Thoracic Society statement. So I want to thank my collaborators, and then I look forward to our panel discussion.
Thank you very much, Mary. That's great. And I want to really kind of dive into the idea of structural barriers, and I want to talk a little bit more. There are already questions queuing up. I want to make sure we have an opportunity to think about this, not just from our urban underserved perspective, but also think about this from the perspective of populations that are rural and underserved populations and Native American population as well. So what I'm going to do here is I think we're going to allow Dr. Pettery to really talk about his experience, and then we're going to bring those questions together, because really what we'd like to do is talk about this framing of the disparities, these questions, hold on to your questions for Mary's talk, and then as we expand to our panel and others after Dan gives his talk, I think it'll really give a broad view of all the barriers for underserved patient populations. And then later on, we'll pivot to technology and thinking about how technology will help or exacerbate certain parts of these disparities. And that's really how we'll put it all together. So if Dan is ready, we will go to you giving a few minutes a talk right now, and then we'll come back to the questions in a second.
I want to thank everyone for the kind invitation. I know most of you have no idea who I am. I'm from Rapid City, South Dakota, and if you can bring up my slides, that would be great, and I can go through some of those. So I'm a radiation oncologist in Rapid City, South Dakota. I just want to give a little bit of a background. I'll try to be brief on this, but I have a cancer disparity program called Walking Forward. And next slide. So the Northern Plains American Indians have some of the highest death rates in the nation for screen detectable cancers, in particular for lung cancer. Next slide. The area that we're talking about this is Western South Dakota, where I live in Rapid City. We serve the natives who live on the Cheyenne River, Pine Ridge, and Rosebud reservations. So probably about 15 to 20% of our cancer population comes from Western South Dakota, or as part of the patients that we serve. Next slide. Walking forward is really divided up into phases. I've called 5 phases, is delineated by the funding that we've had. This is really a cancer control program with a strong emphasis on patient navigation, access to screening, early detection, enrollment on clinical trials. A relevance to this discussion, we completed a randomized controlled study on smoking cessation with about a 25% smoking cessation rate with 4 different interventions. We're now in the middle of our lung cancer screening project that I'll launch into in a moment. And then we just received another R01 for initiating palliative care. So really, I would say like Dr. Pasquinelli, who also approaches this from screening to detection to now the lung cancer clinic that she has. I live in those spaces, I would say, continuously, and really the motivation for starting the program. Next slide was, as a cancer treating physician, I have no impact on how patients present to my clinic. And so it was really an effort. I have about 10 staff that work with me, and 2/3 of them live on the reservation. And they've really been the key to gaining trust in these communities, because it takes about 1 to 2 years to really ramp up these programs. So some of the stats from our part of the country, especially in the reservation communities, high rates of smoking. Northern Plains American Indians, again, have some of the highest lung cancer mortality rates in the US. This is just data shown from our cancer registry, demonstrating that majority of these patients are presenting with stage 3 and 4 disease. Next slide. So this particular research question we did put in for an R01. It wasn't funded, but Bristol Myers Squibb Foundation, have to acknowledge them. They provided the funding for this current project. But the research question is, will provider and or individual level interventions increase the utilization of LDCTs in high-risk smokers in Western South Dakota? And the metric that we're really looking at is to increase the rates of screening. This is being done by educating primary care providers, which may seem a little bit odd as a radiation oncologist, but my roots are in primary care, and their clinical staff, as well as community members in Western South Dakota. Next slide. So aim 1 is screening awareness, building on a lot of work that we've done in the past for other screen detectable cancers. We're looking at initial and follow-up surveys for community members. Number 2 is evaluate the efficacy of 2 intervention with primary care providers and community members to increase the awareness of LDCTs. And then I'll talk about aim 3 in a little bit. Next slide. So it's a 2x2 design to target 135 providers and 1,000 community members. Both interventions include an education introduction to an online resource that we have. And again, the obvious metric is to increase utilization rates. And this is the first project that we've done that includes not only the Native Americans, but also everybody else who is at risk. So we're considered to be the frontier population. I live in that flyover state when you go from Boston to LA. We're that big dark hole when you look out your window. All right, next slide. So Western South Dakota, what you see in the triangles are the LDCT centers. Those are concentrated mainly in the Black Hills. There's very few in the rest of the state. There's one in the middle of the state in Pierre. Because I've lived here for 21 years, I almost have a majority of these people on my cell phones. I know how to track people down. They're used to Peter Wright hassling them by emails or cell phone calls. And then the interventions are really looking at within 3 different geographic areas: provider intervention, individual intervention, or both. Next slide. So these CME workshops that we have, it's about 30 to 45-minute sessions for the primary care providers. We've conducted 95 of these sessions. Target goal is 135. For our community workshops, so we're about halfway there. To date, we've had 100 LDCT referrals. Next slide. This just shows the baseline. So what we do is for each imaging centers, we have an arrangement with them with every 6 months. We have access to how many LDCTs have been performed. So it's going up per year. Next slide. What you can see here is a steady increase until the obvious COVID issue hit and rates went down dramatically. And I'm sure that will come up in the discussion. Next slide. So challenges. Indian Health Service currently does not perform LDCTs, and we're trying to get them up and running in Rosebud. In fact, if they refer a patient for an LDCT through contract health, it won't be covered. So a lot of what we do is trying to gain the trust. It's required to go down and talk to the tribal IRBs. They all have their own IRBs, and they accurately pointed out 2 years ago, well, that's great. You're going to be here promoting screening, and we can't cover or provide for the LDCT. So we ended up getting about $150,000 from this foundation to screen American Indians that don't have insurance. And one really thought that Dr. Pasquinelli's talk was terrific for a number of reasons, but a lot of our patients have a 30-pack year smoking history by the time they're in their early 40s. So we don't have to go through CMS criteria for this. In fact, we can screen anybody we want as long as we think it's reasonable, because we have the money to pay for about 200 LDCTs. In fact, a lot more with the money that's left over. IHS is this is part of their policy, but it's known as life and limb screening isn't a high priority, but we're working with those issues. And obviously COVID was a big, for all of us is a major impediment as well to screening. Next slide. I like this slide because it really kind of emphasizes what some of the barriers that we face. So what you see in this slide here, this is one of our staff in Pine Ridge. This is about 5 miles north of Wounded Knee Massacre, so that has a lot of historical relevance. She met this couple down a road after a blizzard to sign the consent form on the hood of a vehicle. I mean, it's just crazy stories, but our staff, because they live in the communities, they know how to track people down, but this is definitely rural America. Next slide. So next May, we're going to have a policy symposium, including the ASCO presidents coming out, a lot of heavy policymakers in the US. Betty Jacobs is one of our partners from Georgetown University, but we're going to be inviting IHS to this and a lot of other national figures where we hope to influence IH policy about covering LDCTs. In the interim, we're able to provide that service ourselves, and we can get into that, how we actually track folks down to screen them. But eventually we want to make this part of IHS policy, so it's not just life and limb. And I'll stop there. Thank you.
Thank you very much, Dan. I mean, again, I've said this earlier before, it's great to be with like-minded folks who've been doing innovations in our communities. I'm going to take the MC's prerogative first and just, I'm going to ask a question and first to Mary and then to Dan. You know, I want to talk a little bit. I mean, you mentioned, Mary, in your talk and your excellent talk, a little bit about, you know, how the current criteria are not capturing, you know, some of those who are most at risk. And even when we go, you know, to the expanded criteria, we're still going to miss some folks. And I guess what I would say is, if we have underutilization at the current criteria, and even when we expand the criteria, we're still gonna miss people. What's the missing ingredient? I mean, how is it navigation? Like, how are we going to get this, you know, beyond the impediment where we are? And I say that for urban underserved, and then you know, Dan kind of turning it on to the kind of the rural situation. How are we going to get navigation? But first Mary, and then we'll talk to you, Dan.
My one-word answer is educate, educate, educate. That's one thing, but. So there's a lot of barriers. So I'm talking about a policy barrier that we have. And then there's institutional barriers, and then there's individual barriers. And what we're doing at our hospital, actually, because of some of the barriers, we actually changed our lung cancer screening from a decentralized model to a centralized model, where we added another nurse practitioner and we added on navigators. So they're out in the community. We have 13 federal qualified healthcare centers out in the community with navigators to talk about this. And then we're constantly talking to our physicians. So we're changing it to a centralized model that all the PCPs just need to identify patients, and they can just refer them, and then we will take it from there. And we believe our uptake is going to be much higher with that. The other barriers is those individual barriers. So patients knowing about screening, and then a lot of patients don't know about screening, but if they're referred, if they're identified, then we can reach out to them and talk to them about screening. And now, because of COVID and the ability to use telehealth, we can reach those patients easier to talk to them to see if they meet eligibility, and then we can talk to them about their barriers. Some patients have barriers of transportation coming into the clinic or to the hospital to get screened. And so using telehealth decreases that barriers. Other people need transportation, they need other social services, and then we can get our social workers involved to help them with those barriers. But it's not a one size fits all. You really need to look at the individual situation, and then we kind of have all hands on deck to help these patients and help our hospital to screen as many patients as we can to save lives.
Thanks, Mary. So Dan, coming back to you, I know the challenges are unique, but starting first with the navigation piece, you have a lot of ground to cover. And, I just was wondering a little bit your thoughts on this too, as we're expanding the criteria, we're trying to get more, what are some of the areas that you would like to see besides the coverage, which is, one of the major issues, but beyond that would help your population?
So we approach it from a multifaceted approach where within our own, so Monument Health probably owns a majority of the healthcare facilities out here. And they actually have an Epic button for an LDCT. In fact, there's a walking forward Epic button where we get billed. So within all the primary care providers, we've been out there talking a lot about the value of LDCTs, and we know that they know the value, but a lot of this is a time issue. In the tribal communities, we're out there promoting on the radio. Keeley Radio is one of our main mechanisms of communication. We've set up a whole process to, we have the referral forms for the primary care docs. Our navigators are out there doing community education. I'm out there on the radio. All they have to do is fill out a form. It gets to us. So we're trying to approach it from a process perspective as well. So it makes it much easier for them. We realize how busy they are, but I think, with 18 years of doing patient navigation and gaining their trust, we are seeing some improvement. And our rates were really going up before COVID. Now I'm going back down there again. Right now, there's a lockdown on the reservation where there's actually border patrols. They won't let patients leave unless it's life and limb. If they come up for cancer treatment, they let them come, but screening gets to be a little dicier.
Yeah, that sounds, again, sounds like as we're going through a higher bump on COVID too, I know anecdotally, many of us, I've been seeing, that there's a period of time in my own oncology clinic, I didn't see a lot of folks coming in and then post, right probably, I think around June, all of these late stage cases came in. And I know it's only anecdotal, but I don't know if you're seeing the same thing, Dan, but it's really quite something. So that's really concerning, right? That we're going to see this again in the second wave.
And then ACS had an interesting report out recently looking at the screen detectable cancers, how the mortality rate is starting to increase again for more advanced stages of disease. So we're going backwards again. So it's another negative fallout from COVID. And out here where a lot of communities are housed and families are in a small area, that just increases the rates of transmission. So it's a very imperfect storm or perfect storm from a number of perspectives.
So I think that's a good point. We're going to come back. I know this technology piece and where telehealth fits is going to come in a little bit more in the second half, but I want to ask some more questions. There's an audience question, and this one's for you, Mary. Talking a little bit about how to overcome the inherent bias. So for all of us methodology wonks out there. So how do you deal with the bias due to race, gender, and age, depending on whatever use case you're talking about when you do your analysis?
So I try to neutralize everything and have all my patients I treat them all the same. And when they come in, even when I talk about smoking cessation, to be very much non-judgmental. And so we talk about their risk for lung cancer. And a lot of times I even start at when I take their family history, and I talk about that they have their parents smoked, and so they were exposed to secondhand smoke. And then I talk a lot about what the tobacco industry has done to have smokers, to lifelong smokers, that this is more of an addiction. This is not your fault. And then I try to normalize and neutralize that so we can have those deep discussions about their risk. And then the whole teachable moment of showing them the scan and showing them the nodule and showing them emphysema, that they don't see that, they've never seen the inside of their lungs before. And this can be a major teachable moment. And just to really reach out to any patient that is at risk, it doesn't matter who they are or what age they are, that they need to get the same high quality care no matter what happens. I also talk to my providers and my MAs that screen patients and asking about smoking cessation and asking about their risk before they come in, that they are doing that also in a very non-judgmental way. So it comes back to really trying to get the word out there about implicit and explicit bias, and to be sure that that is not being carried over into our clinic.
Yeah, and I think I was going to jump in here and then and just ask. Dan actually talked a little bit about the building trust, and I think whatever the community, vulnerable community you're working in, figuring out the tonality that works for them. this is, as you've heard many times, many people are saying in this, it's not one size fits all. So like, we're in a federally qualified health center as well. 70% of our patients actually are African-American, but 30% of them speak Spanish. There's a Dominican population, and then there's a immigrant African population. And what we do with our navigator, we end up tailoring this very specifically depending on the patients coming in and what they need from us. So, I think that's the key. And I think sometimes this one, the idea that one size, one way to describe this fits all just really does not work. How you might describe this for a working poor community versus how I might describe it when I see folks at the main cancer center, completely different. And that's when we're not dealing with distance, and we're not dealing, we're dealing with some cultural dyads that are similar. You're going cross culture, cross gender. I think again, being mindful of how to tailor it. I didn't know, Dan, if there's anything else you wanted to talk about regarding that and tailoring, and how do you deal with the inherent bias, and how do you folks deal with the inherent bias when you're dealing with a really an oppressed population, a population that might have trust issues, as you mentioned before.
I mean, that's been the key. I mean, obviously I'm not Native American, but I grew up in the state, and 3/4 to 2/3 of our staff are Native American, American Indian. So we call it listening to the signals. What is the community telling us? I mean, we avoid the helicopter research. I'm coming in as a white radiation oncologist to fix a problem. We know there's an issue. How can we partner with you? We're doing the same with our palliative care project, but couldn't agree with Mary more. It's education, education, education. And you want to try to make this as generalizable as possible. I mean, you could argue, well, that's Western South Dakota. That's a little eclectic group, but I think there are lessons learned that can be broadly applicable, and the emphasis, the gaining trust, navigation, and being part of the community. I mean, I can't do any of this sitting in my office. It has to be a lot of road time. So the first 2 years were extensive road trips, which were about 300-mile round trips. It's a lot of road time, but it's paid off over the years because they know who we are, and I think they trust us, but it's a trust that has to be nurtured. So community presence, education, going back to this radio station, that's been one of our best means of communication, because I'll have patients call in and say, hey, can I come up there and see you right now? Like, well, I have to get back to the Rapid City, but it's one of the ways they communicate. And obviously social media, that's very active as well.
Yeah, I think one of the byproducts of this conversation and conversation about structural bias, racial, barriers, structural racism, structural classism, and having that conversation, and it really, we can have these conversations a little more openly. A colleague of mine once said, we weren't as physicians able to talk about social justice. We used to have to talk about built environment as clinicians in general, right? The built environment issues, we talk around it, but we really didn't talk about, specific issues that are really affecting our poor, working poor, and vulnerable and oppressed communities. And I think it sometimes opens a door. And so I think, one of the things of being able to use the language to really talk about this has been helpful, given, we're talking about saving lives in such a situation for lung cancer. There's a question here, and I'm going to expand our panel a little bit, and I want to give a heads up to Dr. Mulshine that he might want to, this might be something he might want to address as well. Dr. Granis has asked a question, and I really think, this is it's a question policy-wise, and for those of folks who, and a lot of folks I'm sure who are participants might have more of an answer and opinion to this. So the question is, what Dr. Cance is calling the Paul Newman syndrome. Mentioned that, Paul Newman died of lung cancer 23 years after quitting smoking, and that the CREST data show that limiting lung cancer screening to those who quit less than 15 years excludes more patients than extending to age 50. And the question is, why did U.S. Preventive Task Force extend the screening to age 50, but not to those like Newman who quit more than 15 years earlier? And, as I think many of us trying to get into the minds of what's happening on the U.S. Preventive Task Force is tough, but I didn't know if either Jim or anybody else in the group wanted to take this about, some of the thought process on the extension. I didn't want to skip the question. I thought it's a really important one. I don't have a specific answer, but I know that I'm going to call on the assist from our other panel members to maybe answer that question.
Thanks a lot, Chris. This is obviously such important material that you're discussing. And I appreciate Dr. Granis's concern. In reading the discussion of the proposed solutions from the U.S. Preventive Services Task Force. As Mary kind of indicated, they said, well, this goes partway to mitigating this. And, you know, that just seems like we fall backwards in that regard, as well as in our screening rates. Yeah, if we have something that can work for people and prevent them from dying, you know, and it's not expensive. And the data that has emerged since the last time the U.S. Preventive Services Task Force did their data review, with Linda Humphrey's very nice articles in the annals and whatnot, there was legitimate concern about, you know, complications from diagnostic workups, complications from screening operations for detected cancers, inefficiency over diagnosis, whatnot. In the last 10 years, we've seen with the maturity of the data from the NLST, the new data from the Nelson, additional data from lots of other international centers, that the safety and the cost effectiveness of screening across the world is reasonable. Screening is a balance of risks and benefits. We now know the risks are not as great as we at one point thought or feared. And so that should be the biggest balancing point for benefit. If we know that there's at least as good a benefit and possibly better benefit than we originally thought from the NLST, we know we can deliver this safely, efficiently, and we're having an uphill climb to getting people to come in the doors. Why are we chasing people away? It just, you know, this doesn't make sense. And so I think what, you know, Mary is proposing is a very clean, objective way to looking at this, but it begs the larger question of justice and about who are we? And we've got a service that, you know, we're going to be talking about how it informs about the other tobacco-related problems, and we can have a larger conversation about health and a larger conversation about helping people to understand how they can protect their health, sustain their health, nurture their health through very simple, you know, physical exercise, diet, enhanced tobacco control. So I could go on for a while, but I want to hear from your panelists. This is a wonderful discussion.
So thank you. I had a feeling that starting off with Jim would be the right thing, because I want to set that right tone. I think, you know, again, leading into the justice part of this is really important. And, you know, again, you know, thinking about, it has always been baffling for both those of us who've been fighting for this, you know, how those decisions are made. But to kind of bring back a little bit, you know, I'm going to ask the member on our panel who is a cardiologist, Garth. I'm going to bring you out, and no, because we're all very close to this, right? All of us have been very close to this, and I think I want to ask Garth what, you know, kind of your thinking, and I'll be very specific on this. So as we're talking, you hear us talking a little bit about lung cancer screening and innovations in the community. You know, give me an idea when you're thinking, when you maybe go back maybe 5 years ago when you were first starting, when you're thinking about interventions in the community, conversations about lung cancer screening, and you know, how you are viewing the justice issue that you heard Jim outline so well, and you know, kind of framed by this question that Dr. Reanalysis asked, which is really, you know, what was your thinking, I think, as a cardiologist, you know, not someone so close to this, perhaps, about vulnerable communities and lung cancer screening and this justice component, if you mind if you comment?
Yeah, no, Chris, really good point. You know, and it's interesting. I think that risk factors for coronary artery disease, smoking, you know, some of the things we just talked about in terms of diet, exercise, and all of those colloquial things that lead to the metabolic syndrome. Those, you know, kind of lend to risk factors in so many clinical areas, including lung cancer. And certainly smoking being that one universal evil that I think crosses a number of kind of clinical paradigms. You know, I have often wrestled with this concept of the degree to which we extend screening capabilities, screening guidelines versus, and this is where Jim was going to, kind of universal precautions. Maybe that's the terminology I would use in terms of the kinds of things that span a lot of different disease entities. And it goes back to that, I could go on and on, which I am going to go on and on for one more minute. But it goes back to this sometimes over-reliance to some degree on the technological tools that we have, and whether those tools actually increase capacity or life expectancy, and to what degree are we able to actually pick up diseases at a population level ahead of time and make clinical decisions that make a difference versus just diagnosing, versus just picking up something. And since we're talking about lung cancer screening, an often paradigm that comes up is this, coronary artery calcium. And when you screen for lung cancer and you pick up a little bit of coronary artery calcium, what does that mean? Does it mean that this person really has something that is going to lead to acute coronary disease? Does it mean that I could have coronary artery disease, or is this incidental findings? And I think Joe was going is where I think I've landed with in a non-scientific term, although my group did publish on some of this around hypertension and coronary artery calcium score, and the degree to which the clear difference on when to act is still not there. Let me put it that way. And so I still go back to so many times, I think just where you're going, taking a step back and saying, how do we continue to emphasize those things that we know do work? And how do we spend our efforts, both at a population level and in an individual patient conversation, to talk through the things that we know do extend life expectancy, and those things do still come back a lot to, those discussions around diet, exercise, smoking cessation, or at least the things that go into that. And so I think I often have wrestled with that clinically, and I think have come around to the fact that we put an overemphasis on our tools. I need to put more of an emphasis on the things that are going to actually change the patient outcome.
So this is why I asked, because I knew because I think it's important. No, I think it's important to get and thank you, Garth, for kind of giving us that overview of how you think about it. And I think this conversation about is the diagnostic good enough? I look, as we kind of circle back on health equity, and this is something that I think is really important. As we one of the things that I think, and this is, I don't mean to editorialize, and I certainly want. Carolyn, if you want to talk about this after I set this up, I'm thinking about prevention in general. So one of the things I think is important as we talk about health equity, and as we're thinking a little bit about touches to the system, right? So if you come in for your CT scan and we get an opportunity for your low-dose CT scan, and we get an opportunity to deal with your tobacco cessation, we get an opportunity to touch base from what we get from the CT scan to incidental findings, and link you back to your primary care doctor and have more conversations. I think especially for underserved populations, sometimes that might be the only time folks are going to come in. And that's what I think, and our data is so strong. And as you heard earlier, quite passionately, from Jim, I think the tool is good. And I would say that I guess what I'm particularly interested in, as most of the conversation in public health is talking about screening less, this is one area where I think if you think about it in touches and diversify what you can do to integrate people into preventive health care from this particular scan, there are different opportunities. And again, Carolyn, I don't know if you want to talk about this, thinking about prevention in general, but I figured I would ask and make sure that you got a chance to speak if you would like on this topic as well. Oh, I think your mic is not on, unfortunately. All right.
Now it is? No?
Yep.
Yes? Okay. So thanks, Chris. I'm happy to have an opportunity to say a few words about this, because this area has been important to our foundation. I started thinking about the fact that the very first program we developed, other than our research grants and fellowships program, back in the 80s, because we were started in 1985 and made our first research grant in 1986. But a couple of years after that, we started really diving into program development of our own programs. And the very first one we developed was a program called Project Awareness, and it was for medically underserved women, particularly African Americans and Latinas, in 4 different cities in the country. And it was a program to get people into mammography and to remove the barriers that were keeping women from accessing mammography. And we learned that you really can't provide access to prevention without removing some of the social determinants of health. So until you level the playing field, it's really hard. And you can't level the playing field when people live in food deserts and when people have transportation barriers to get to a facility, to get a mammogram or to get a CT scan. You can't level the playing field if they can't make it in for an appointment because they have childcare issues. So I think it's so important that we address those social determinants and then begin to talk about the big picture of prevention and early detection, because obviously screening is such an important part of cancer prevention. So I think that's what I would like to say. And I'd also just like to add my thanks while I have the mic. I'd like to add my congratulations to you, Garth. I think that's just such a wonderful honor to be chosen as a member of the National Academies. I mean, not many people can claim that and put that into their email signature or their bio or wherever they want to put it. But hearty congratulations from all of us. And it couldn't have happened on a better day. So thank you, Chris. I'll turn this back to you now.
No, thank you. Well done. I think I know we're going to get ready. I'm going to get ready to talk a little bit about turning to technology in a minute, but I do want to ask one more question of our panel. And also I want to say I encourage crosstalk, by the way. So if there are things that are coming up, if there are other questions that are coming through and other folks on our panel, who want to ask other questions, please, I will definitely stop talking. But I guess what I want to talk to is touch just a little bit on COVID, and COVID as as ripping off the Band-Aid of the instability of much of our medical health system, not just in the issues with vulnerable patient populations, but really all of our stress points throughout all of our systems, right? I think it's illustrated this quite a bit, and it's also pressed us to innovate in ways sometimes, which I think is great, and we'll hear that about telehealth. I think it could be good or bad, but maybe I'll start this one with Dan. You mentioned a little bit about COVID and how COVID has changed your approach. Are there any things that you've taken from the first wave of COVID that you think you're going to keep going forward in your lung cancer screening approach? So we'll start with you, Dan, and then we'll go ahead with Mary on that.
Well, certainly a lot more telehealth, and we're doing a lot of the outreach with our community members with events that are a little bit more spread out. But I think as a clinician, telehealth is going to become a new standard of care. That would probably be the main thing. The webinars, the Zooms, I think initially we were all kind of like, oh my God, another new thing to learn, but it's actually has benefits. So I think in areas where there's a geographic distance, this can really help. A lot of the patients out here now have phones, computers. I mean, in the past they didn't. There was rural issues with adequate cell phone towers. So I think we can certainly tap into all that. So I do think that is a positive. You're an oncologist, you know what the headaches are now with chemo and radiation patients. I'm a brachytherapist, and for cervical cancer, we see a lot of advanced cervical cancer in these patients, in this population, and they need brachytherapy. I have 2 positive COVID patients. How do you deal with that? And everyone's nervous about bringing them in, but if we don't treat them, they're not going to be cured. So it's a moving target.
Absolutely. And Mary, before you jump in, I was going to say that I can't tell you how many emergency committees I've been on about individual cases for this reason, right? Especially, back in May, June, when everybody was even more terrified and our systems hadn't really figured out what we were going to do. It's been an issue. I would just add on to the bit about the Zoom and tumor boards, and actually beyond that is at first everybody complained a lot about this, but what you've mentioned, it is much more inclusive. So now I have people who are across different parts of the state who all I have to do is send them a simple evite, and then they're on, and we're discussing cases in a different way, pushing things and pushing quality in a different way. It is still tough, I think, thinking about navigation beyond just what we classically think about navigation, but also thinking about telehealth navigation. So how do you do this for elderly folks, for people who speak a different language, making sure that, because even though you can do it on your phone, And, sometimes we can't figure out how do you turn that mic on, right? You got to call the admin, can you get the camera going, all that kind of stuff. We probably need to invest in that infrastructure, which given everybody's cash poor, nobody wants to do. But I think that would really make things much more effective. Mary, I just want to get your thoughts on the COVID and kind of things that you're going to take forward in your screening process.
So as far as COVID goes, at the beginning of our wave, it was very significant to our population. And one of the first patients who sadly died of COVID was one of my lung cancer patients. She was an African-American woman who lived in a very poor community. She was very poor. The only reason why she would really go out is to go to the grocery store and have family members would come over. And I thought within the first week of COVID, I'm like, if she has COVID and I don't think she ever even traveled outside of Illinois. I knew it was so embedded into the communities that we serve, which was so concerning to me. So telehealth has been kind of a lifesaver for that. My pulmonary clinic went 95% telehealth, and my oncology lung cancer clinic was about 60% in person because they had to be treated, 40% telehealth we could call them for those follow-up scans. I did a survey that 23% of my patients did not have access to a computer or broadband, but everybody had a phone, even if it was a landline. And me calling in and checking on them to be sure that they're safe. And then when they come into the hospital, to know that when you come in, we are going to be masked, you're going to be masked. We're following protocols because over 60% of our patients said that they were concerned even coming into the hospital because of COVID. Now I think that has changed as it's kind of everybody's masking and we have policies in place. But at the beginning, it was a very scary time, not only just for our staff, because our hospital got hit very hard by the COVID pandemic, but also for our patients, and to be sure that we are there for them and we're going to meet them wherever they need to be met. If it's by telehealth, if it's coming into the clinic, and to be sure that we are giving care wherever they need to be seen.
Chris, can I jump in here on something Mary just said, and it happened to me at the beginning of COVID as well, where one of the patients I had in my clinic, I remember thinking, as we learn more about this, that man, if there's anybody at risk, it's going to be him. And going back to part of the discussion, and when Mary said, and the characteristics she was describing of that patient, which is very similar to that patient I was seeing as well. And I was thinking, sometimes I wonder if COVID may be the clinical vehicle that impacted that patient's care, but what they had been suffering from all along were the issues that Carolyn pointed out related to social determinants of health. And though, and then going back to kind of the earlier point Jim made around, bigger picture, and then Carolyn kind of made forest from the trees, is, to what degree has COVID been the vehicle that is showing the underlying disease is poverty,
yes,
systemic challenges, and the overused term that your zip code matters more than your genetic code, and all of those terms that we use colloquially to just refer to the impact of social determinants. And that's what I wonder, and I hope is part of kind of healthcare 2.0 that we come out with after COVID, is understanding though that, again, whether it was your MI, your malignancy, your infectious process that may have actually been the clinical tipping point, what you really were suffering from was this overall issue around poverty. And that's the actual disease. And it's hard for clinicians to talk about that because we don't have a prescription for that to readily write a dosage or a treatment plan. But we have to be part of the leadership of the country around the discussion around those issues. And I think Daniel could speak even more to that more than I can, given the patient population he has. But anyway, my long soliloquy was going along the points when Mira's pointed that out, and your point around COVID, and whether I think COVID and whether clinical entity we discuss is the killer, but the disease process that got us there was very different.
I think very well said. One of the reasons that lung cancer and lung cancer screening to me have brought all of these health equity issues together and become a really good example for social justice. Is, you know, all of our oppressed populations, you know, generally, you know, that's the group that, if you think about stigma, we talk a lot in lung cancer community about the stigma for tobacco folks, right? And the stigma getting in the way of the treatment, and thinking about how we think about our patients, and then impairing how we thought about screening in ways that didn't impair other screening modalities, right? It's one of the things that really got in the way. And I think, you know, if you're looking at your blue collar folks, regardless of race, poorer folks, rural folks, and then add on that Black, brown, and indigenous communities, those are communities, and in your LGBTQ communities, which is also being targeted as well for, you know, tobacco and tobacco ads, and thinking about, you know, screening and thinking this is an opportunity not only to get a modality that will save lives, right? It's also an opportunity to try to direct care for folks who have not been able to access care, and to have a greater than the paper impact on your touches. I really think that that's a really important thing. And of course, I'm biased as a medical oncologist thinking that way, but I think it's beyond that. I do think it's important. And with that, I think, sorry, unless somebody else.
Oh, no, I'm sorry. I didn't want to belabor this point, but I was going to say that, and again, Daniel, you know this experience more than I do. You know, where I've seen the school, you know, the community that I grew up in, I've seen the scourge of poverty kill people. And it happens in a very kind of silent way, much like we just talked about and what you just alluded to. But in Native American communities, and, you know, the kind of the scourge of depression, alcoholism, and all the things that kind of go into that. And then it leads to the clinical outcome. I just really feel like this is probably our moment in history to you know, where the public is engaged, and maybe this is where, you know, we pivot and speak maybe less around guideline care, but morally driven care.
And that's fantastic. And I think this is the time we're gonna make a tonal shift here and talk a little bit about, you know, as we build talking about health equity, we're gonna focus a little bit on, you know, on technology, and thinking a little bit about technology. And all of us have been having these conversations, I think, within our centers and outside about, you know, what can we do? There's innovation, technology, and that can be helpful. Is that going to enhance, you know, our access to health? Is it going to be, are we going to strand some people? And, you know, the second half of this particular session is really going to be framed around that. And so we'll be handing off to our other MC, Dr. Garth Graham, who you might have heard has had a very good, you know, a great honor and hopefully a great day, but actually he's also going to be talking to us about information technology and how that enhances access to health information for vulnerable communities. And then he'll be taking over the MC duties, and I will be a panelist. So with that, I am going to hand it off to Garth.
So let me start off by saying how thrilled I am to be co-chairing this session with Dr. Lathan, who has, you know, just an amazing background and an amazing reputation, in particular in this field. You heard a little bit earlier from Mary Pasquinelli talking a little bit around disparities and really kind of defining a lot around what we're going to talk about today. What I hope to do is to set up the next panel where we're going to talk about information technologies and, you know, how can we really use information technologies to access and improve access to vulnerable populations. First, let me start off by you know, taking a vein of a lot of what Mary just spoke about, but thinking and talking about the context of social determinants of health. You know, most of us, all of us really, we may spend a couple of hours, if any, in a doctor's office, but we spend all our time in the community in terms of the amount of waking hours each year. So it's really the community that we live in that defines our health and health status. You know, many of you already know the overused term that we often quote, that your zip code matters more than your genetic code. And this is more looking at that issue of, you know, how life expectancy, how long you live, how well you live is really defined by where you live. And this is just some data looking at differences in life expectancy in the city of Boston. And I'm giving some background here on social determinants to really lead into the context of how technology can be helpful, if not enhance access and enhance care within this context. So this is just showing the life expectancy difference in one zip code in Roxbury versus if you head up on the red line to Back Bay, and showing really here an over 30-year difference in life expectancy. This is some data that a group of us published in JAMA last year, showing the deep extent to which social determinants of health really dictates patient outcomes. And this was looking at patient outcomes related to acute myocardial infarction and the death rates related to that. And what we showed in this slide is that if you look at characteristics that are more common in Black populations versus characteristics that are more common in white population, and create a propensity score that kind of defines both populations, the real big difference between Black and white populations is socioeconomic status. And that's why you see those bars up at the top of the screen are the furthest apart for socioeconomic status. But when you think about medical history, clinical presentation, even health status, and you kind of adjust for propensity scoring, there's really not that much difference between Black and white patients. And what we see here in this next slide is that that difference, that socioeconomic difference, those the social determinants of health really drive mortality threefold when it comes to 5-year difference in mortality in Black and white patients. And that's where you see the trajectory of the graph heading up on the x-axis. Propensity score, meaning the more and more likely you have characteristics that are more present in Black patients. The p-value, if you look at this, is 0.11, and that means that it's insignificant in terms of race. So what does that mean? It means that whether you're actually white or Black is not what's driving the mortality score. It's that propensity score that defines those characteristics between Black and white patients. So said simpler, if you take a Black patient and put them in socioeconomic dynamics that are similar to white communities, then you end up with similar outcomes. But if you take a white patient and put them in a Black socioeconomic dynamic, you end up with similar outcomes there. But the actual race is not what defines this. And so that's really kind of the takeaway. And this is really, again, meant to kind of give you the landscape in which technologies are going to be deployed. But it's not just about race. There are increases in mortality based on geography, and it's really driving down the US life expectancy that you also see in white populations. And particularly along the Ohio River Valley and Appalachian states, you have a tremendous amount of excess deaths there that are being driven by diseases of despair. And really that's where a lot of the concentration of the decreases in mortality that we're seeing. And this is some data that Wolf and team published and have been publishing over the years in JAMA, really looking at how life expectancy is very different, and excess midlife deaths very different in Appalachian State. So what does that mean? It means, again, you have this framework of location that is very much impacting people's lives. And this is a quote by Sir Michael Marmot, asking, why do we keep treating people, send them back to the conditions that create illness in the first place? So within that context, where is the real potential of health information technologies, digital health, those kinds of tools, technology in general, to really close these tremendous life gaps? So there's a number of ways. So one, it has the potential to expand health into the real world. And what does that mean? It allows one to take these tools, the technological tools, out of the clinical settings and into the real world life of the patient. So you think about where you're able to kind of track, monitor, and then feed that back into the health system or the healthcare information technology that is related to that patient from real world dynamics. You also have the potential ability here to generate potential user-friendly tools, scale really to and the population level, and then of course be able to study in a more efficient and representative population. So, there's a lot of potentials there. I would be remiss if I didn't mention some of the 3 challenges that I think can impact our ability to deploy information technology to improve the lives of underserved and minority communities. And the technologies are born on the backbone of things like broadband coverage, internet coverage. So we have to make sure that you have adequate internet coverage. The technologies, as we're deploying them, we have to be cognizant of the concept of bias. And then we have to make sure that as we distribute information technologies broadly, that we don't distribute this to the world well, but to the communities that live in them. This is just a double click on some of the challenges around broadband access, of which a lot of technological deployment lies. And many of you know, we've been following the challenges around education in the COVID era, and know that lack of broadband access for minority children is playing a significant role and may have long-lasting consequences in terms of those kids being able to access educational system. Similarly, those challenges, as you see here in a multitude of low-income populations, continues to predominate in terms of broadband challenges. As we deploy information technologies, understanding that where there might be algorithmic bias, that may lead to outcomes that widen disparities. And so understanding how we use and deploy algorithms is important, but also understanding and correcting if those algorithms may have hidden or unhidden biases that may be perpetuated. And then this is really just kind of a snapshot of, again, the full range of potential partnerships, potential technologies, if you utilize the right partnerships around information technology. So you can go from measurement to diagnosis, treatment, to all kinds of activities around kind of the global nature of information technology. So it's a broad tool that when we use the term information technology, that if used wisely, has the ability to really significantly reduce, if not eliminate, health disparities. But we have to be cognizant of all of the various challenges that I mentioned earlier. I'd be remiss if I didn't end by saying, in terms of setting up some of the discussions for the panel, that it's not about the technologies, it's about the community and the people. And this idea that what we build, we must build with and for communities is particularly important. And so we have to think about community engagement and partnerships along the spectrum, where we go from just isolated silos, or where we just inform communities about these activities, to where we actually build, structure, define, and then ultimately deploy information technologies along with communities. So hopefully this gives you a backdrop of some of the things that we're going to be talking about and digging a little bit deeper in today, but really wanted to set the stage here for understanding the potential, the challenges, and then a way forward. Thank you. Hopefully that was at least give us some foundation to start a discussion. Now, the interesting thing is, I think Mary and Dan and Chris, each of you have had experiences along these lines, especially within the COVID era. And I thought we could start off, Mary, maybe with you, with a question about what you've seen around the opportunities with telemedicine. I know you've been part of some specific activities that has been insightful there. And then the challenges, and then what do we take away for this for, a healthcare 2.0 kind of post-COVID?
Yes. So I have seen a lot of benefit from telemedicine. We quickly did this survey looking at our patient population, pulmonary medicine and cancer in these two clinics, and looking at to see which patients have the technology and which ones don't, or have what type of technology. And then if they were able to access a telehealth visit, how they liked it. And if after COVID, what do they want? Would they prefer to have access to telehealth, go back into the clinic, or have a hybrid? And 90% of the patients that had a telehealth visit said it met all of their needs. It was just as good as an inpatient. Now, these are patients that already had a connection with their provider. And over 60% of these patients, I think it was around 62%, wanted to have the option after COVID to have that ability to have telehealth. I think only 23% said they definitely want full inpatient or in clinic and not have telehealth, but over 60% wanted to have that option of telehealth. The problem though is right now telehealth is covered because of the emergency mandate of saying that it needs to be covered, but there may not be payment parity for video conversations versus phone conversations only. And as I said, many of our patients do not have access to a video telehealth, but only a phone telehealth. And that will make some disparities also in payment, and also being able to, I would never have my patient come in because they can't do a video telehealth visit. I will do it by phone, even if I get paid less. But I don't think a lot of people across the United States may feel the same way. So I think that there are some barriers to that. And then also just to constantly use every visit and every touch point you have to be sure that the patients have the care and have the what they need to stay healthy during this period of COVID.
Yeah, and that's interesting hearing just how accepting, if not wanting, patients are the technologies and how it can potentially fit a specific need. Daniel, how about your experience that you've been seeing across different parts of that community?
So, I mean, I agree. I mean, it's true that you get paid less for doing a telephone call than telehealth, but at the end of the day, I don't really care. I just want to make certain we're communicating with these patients, and my experience has been the same. They're so appreciative when you call them, even if they don't have the technology or if they can't figure it out, to get on my chart with Epic or whatever EMR is, just to have someone talk to them. A lot of these patients are really lonely too. They're just glad to talk to you. It is going to be interesting to see how this is going forward. They're trying to revamp the platform here for telemedicine with a new video system. But I'm like, if our patients don't have access or phones that will accommodate this technology, you're wasting your time. So to me, it's a little bit of a point of frustration. I mean, as a radiation oncologist, patients have to come in for their treatments. So a lot of those folks, all those folks are coming in, but for follow-ups, I mean, the reality is for routine breast and prostate patients, we can call them. I mean, a lot of these ranchers live 1 to 2 hours away, so they're happy not to drive in. So I do think there's going to be a shift in how we deliver, routine follow-up for these patients. For consults, I'll often tell them if they don't want to come in, you might want to come in later so I can go over your options for prostate cancer. It's hard to visualize what brachytherapy consists of, or putting in hydrogel devices. They can get on the internet and look it up. But I do see that it's going to be a blend. And I think for the Native communities, most of them now have cell phones. One guy I was going to bring up that I met, his name is Michael Bucinelli. He's down at the Stevenson Cancer Center in Oklahoma City. He is a rock star when it comes to using cell phone technology. He has all these grants working with homeless people, assessing their needs. I'm like, this guy is ways ahead of a lot of people, especially me. I'm like, wow, you can do this with people that are homeless. So it is going to open up, I think, more doors for us and hopefully access patient care, in particular for the Native population. Those folks here that are being confined or locked into the reservation, it's the only means of communication.
Mm. Yeah, it's interesting around cell phone technology, and the clinicians and researchers were able to utilize and maybe explain how we do that better. I'm definitely not one of them, though I think believe that is part of the future. Chris, how about you? Kind of what have you been seeing in your practice and experience as well?
Yeah, so I think like Dan, I've been a little bit of the institutional gadfly at my institution, because I would say that, on one level, once we went, a lot of really smart folks figured out how to put a platform together, and they had to do it real quick. And I want to just get that out there. They had to do it quickly because we needed it. But it was really speaking to, because I'm in two different places. I'm in the Quaternary Cancer Center at the Dana-Farber, where 70% of that patient population has at least a college degree, right? And then I'm in my community practices, which is very, very different. It's older, it's browner, it's poorer. And so at the main Dana-Farber campus, this went, and people liked it, and everybody was happy. And look at all, in video, right? They had people, and it worked well. But then when I went to my practices where we were talking a different patient population, it was a struggle. And there are two parts where I felt it was a struggle. One was elderly patients, and then the other was language and different cultural issues. So my interpreters, we already had a way that we would do our interpreters. Now all kinds of things were happening. There was Zoom, you had to get an email, Zoom visit link, find the interpreter, right? And all of these things made it very hard. I think many of us spent time sitting on a Zoom visit, doing things like this. Okay, your camera's, I can't hear you. And then just calling them, right? And I think the patients were frustrated. Those of us, if you're a busy clinic, you're running late, how do you let that patient know? You can't send a CA into the room and say, hey, Dr. Lathan's going to be in a few minutes. They're just sitting out there. So I actually pushed the Institute a lot on saying, if you're going to do this, and this is something that Dan was saying, we need real infrastructure to do it. We really need to have infrastructure to do this. You need to identify who those people who need help, and whether that is, do they actually need like an iPad at home, or do you need to help them? We need to figure this out, right? We need to figure that out, and then we need to explain it to people. What's amazing to me is that people know how to text. Internationally, WhatsApp, people can do all kinds of things. They can connect all over, and this is getting to Dan's point about the homeless population. So one of my nurse navigators taught me this in my FQHC. In the beginning, she would give her phone number out to everybody. And I said, well, maybe you shouldn't give your phone number out to all the patients, thinking like a doc, right? You probably should, have something different. And she said to me, they're not going to answer the phone, but they'll text me, and I can text them. And that was like, we've been working together for almost 10 years now. And I see that now, and that's still true. The problem is we haven't used the platforms that are intuitive, that people have already accepted. We built another platform for us to bill on. And I think that and it's safe, right? But I'm sure if you there are ways to do this that could get to a broader patient base. And then the last part about this, and now I just feel like a grumpy person, I miss touch. And I mean this in a way that, look, there are some places, oops, sorry about that. There are some places where I think, like my long-term follow-ups who, I'm a lung cancer doc, so I have some of those folks who are long-term follow-ups, great. People who I'm doing sick visits with, like Mary said, I will call, even though there's pressure on me not to do a phone call to actually, get to it, but I'll call them and talk to them. And that's fine. But quite frankly, I'm giving toxic chemotherapy to people. And if my nurses are exposed, right, because the person's coming in, I'm not going to hide somewhere else and do a video visit on it. And the patients, sometimes they're lung cancer patients. I need to listen to their lungs. There's some people who haven't had a stethoscope on their chest in a while, and they haven't had anybody, talk to them in a while. And it's also the last part of that. If you don't already have a relationship with somebody, it's hard to have end of life discussions, complicated discussions about diagnosis and screening. It's hard to do that over video unless you already have already have a relationship. So I see areas where it's helped. As I mentioned, tumor board, I think is better. I don't care how much my pathologist complains about not being able to share the screen, it's better. We'll just get on board and do it. But, I think some other areas, we got to acknowledge where there's some gaps. We actually have to fill in the gaps with appropriate navigation. And we have to engage. Again, we've never engaged our community about this, not until afterwards. So we didn't say we didn't have a chance, but these are all the things that my concerns about how you can exacerbate disparities in some areas and have the people who are already familiar with the technology really, have it take off.
So I love that story, Chris. And Mary and Dan, we're going to come back to my next question is going to be about what you think are the challenges and ways in which we may be exacerbating disparities. And I think we see a lot of that even in education. I will tell you though, your story about your outreach worker who was working with you and was communicating with you text message, always just emphasized to me how I think in many ways in medicine, we create a separate world than the real world that patients live in. We all communicate colloquially with, important things, even with our families and friends in ways that we would feel uncomfortable communicating with our doctor on. And you think about that, and you think about how, in some ways, a clinical delivery system is still stuck in some other time period. I'm not sure what time period it is, maybe the late 90s, early 2000s, but still is not totally caught up, though I think COVID has transformed some of that. But But I think about that point, you know, when you look at little children, I have like a 5-year-old kid that's attached to me. And, you know, my son is able to do all of this stuff, which I'm not totally comfortable with. But he's at least, you know, savvy enough. And I think that at least their world, they're not going to be accepting of not being able to communicate in a way that they're used to. So I think part of as we think through what I consider healthcare 2.0 after COVID and kind of what it looks like. But anyway, interested to hear Mary and Dan. Mary, we'll start with you. You know, to Chris's points, you know, what are the challenges that you see? What are the things we need to fix? And you know, what do you think we need to be doing to get from where we are to where we need to be?
So there are we kind of highlighted these challenges with technology. And I do think, you know, right away, I'm like, oh my goodness, another disparity that's going to happen. The wealthy people are going to have all the technology and can have these doctor's appointments. And the poor people, once again, we can't access or jumping through, you know, more hoops just to get the basic care to them. But we got to do what we got to do. And so that's one thing of really trying to figure out. And I hate to also say this, I give my cell phone number out to all my patients. I don't say you should do that, but the texting, I have patients that are so anxious about scan anxiety. They will text me 5 minutes after they got their 3-month scan and say, please, Mary, can you just take a look at the scan? It is a safety blanket for patients. And I would have to say that not many people abuse it, which is good. And I've learned all these other apps that I've never thought of. My patients, I'm like, what kind of app do you use? Okay, I can do download WhatsApp. Whatever they want me to do, I will do it in order to get to them. The other thing I kind of wanted to mention that kind of plays into the social determinants of health. I got a grant a couple of years ago for my cancer patient in the cancer clinic that I started in the lung cancer clinic, but we have expanded it to all of all the cancer types. And it's screening patients for anxiety and depression. And then also on the screen, we have some other issues of, do you have problems with transportation? Do you have problems with food insecurity? Do you have patient problems paying for your bills? Do you have so it kind of lays out a lot of their issues. So right away, we can see their anxiety and their depression and a lot of their barriers to care right when they start to meet us at the clinic. And then we have our social worker, and we have a resource for every one of those that they say yes to. We have a resource to help them out. So if we can identify at the very beginning when we meet our patients, what are your barriers? Because everybody, you may look the same, but our barriers may be different. Our barriers may be problems. I don't have transportation, or my husband just left me. I'm living in an apartment with a friend, and I only can live there for another week, and I'm going to not have housing. But we can work with our patients to be sure that they get the care. We don't have to just be a doctor that takes care of lung cancer patients. We can be doctors that take care of patients and treat them holistically. So I think, and it doesn't matter if it's looking at this through telehealth or looking at this inpatient, just to be sure that we are thinking about those social determinants of health, that we are meeting our patients to improve their health outcomes.
Well said, Mary. Dan, what are you seeing as some of the main challenges, especially given the world that you have lived in for the past 2 decades?
Yeah, I mean, trying to make this as generalizable as possible. I think most people on this call are living in the world of going from cancer screening to actual treatment. I mean, those are 2 separate but overlapping worlds. I do think, I like the previous comment about investment in technology. As our hospital spent an unbelievable amount of money in implementing Epic here, I'm thinking, what technology do we have where you don't read the manuals? It's your iPhone. Our kids can show us how to do this. If someone should figure this out, it's probably Apple. Have them make an app for us. Investment in technology, I think, is going to be important. I think the navigation part for us. And so when we were the first group out here to have patient navigators 20 years ago, and our own hospital has implemented navigators for breast cancer, head and neck, other sites. In the cancer world, there's at times a tendency to get so locked into their treatment, but we have a patient support and cancer rehab team. You need to take care of the whole patient, obviously. But again, I'm kind of feel like I'm bouncing back in both worlds between being on the reservation, promoting screening for the LDCT project, the other screen detectable cancers, to now they're coming up here for treatment. How do we get them through this? How do we deal with this in the post-COVID era? Hospitals are going to spend the money to do this. And I at times feel a little bit irritated that, okay, well, we want you to start doing all these telehealth with this new video system. Well, what's the motivation? Is it really for the patients, or is it for you to get a higher billing code? And so a lot of our patients it's too clunky. And I agree, get on the phone. Well, they don't know how to turn on the camera. I mean, you're getting into the minutia, but big picture stuff. I think this will force hospital systems to invest in more technology that's user friendly. For us out here, as Mary said before, it's education, education, education. I'm also disappointed I can't get down on the reservation to talk on Keeley radio, but we set up some ability to do that remotely. Patients are starving for this information. And so I guess those would be some of my initial thoughts. And then, more globally, we in our group, we need to work on influencing policy, which we'll do. But, in a way, this is a perfect storm that may just force a lot of these issues to become evident to the general population. And hopefully that's going to force solutions.
Chris, I know you started off us down this path, and maybe closing it off on this particular topic around challenges. You're going to be specific about whether the challenge you're facing, and I want the rest of and I'm going to throw in my own thoughts too, selfishly, and then I think I want us to segue after that to think about what do we, you all deal with very complicated diagnoses. And I think the next thing to think about is, how do we think the tools we either have or need, or what are the tools we need to really help patients navigate life or death when they are probably the most vulnerable, and what are the things they need to do. But Chris, I'm interested in hearing your thoughts on challenges as well.
So on the challenges part, I think, I want to pick up a little bit on what Mary mentioned about identifying the needs of your patients before they come into the door, especially those who need resources. So I think if you think about, screening, and we're going to talk about lung cancer screening in particular, I think that, again, if to me, one of the things that's always been missing is how does a patient, they come in, they do registration, their insurance, their zip code, but you don't necessarily know if they can't pay their bills. Even though, I think we published like JCO, it seems like a billion years ago, like 2012, 2013, somewhere around there, where we really showed that you can ask these questions. We know that in breast cancer, they showed you can ask any question. You can ask a cancer patient any question, they would answer them. And yet we didn't really ask our patients what sort of resources they need. Actually, some of the data showed that the best way to get a social worker is to cry in the room with your physician, because then we run for help and we get somebody, which is a shame. You really should be. And that's, so the first place to me where technology, and if you think about this for screening, why aren't we, as you pointed out, our phones are so intuitive, why aren't we able to utilize that technology to interact with our patients in an appropriate way? I could do easy language translations. I can't tell you how many of these patient reported outcome survey apps, or these apps that are supposed to reach out to the patients, are in English only. And then when I say to them, okay, well, what about language? Well, we're going to get to that. We're going to get to that. The first iteration is going to go out there and it's going to, oh, okay. And then when you're going to get to that, you're going to get to that later. So I think, to me, the biggest challenge is to get the technology people, and Dan talked a little bit about this, their marketers know how to intuitively connect with communities. What's happening is we're not talking to the communities that we want to connect to. It's just, not to oversimplify, but that's a huge challenge here. You want to do your patient-reported outcome nifty app device, that's great. I guarantee you almost every hospital, it's going to work in this population that everything works in. And they haven't really given a thought about how it's going to work in the other folks. And when they do, they're going to say, ooh, you're going to need some more resources for that. And then it's considered not as important. And that's true whether it's rural, unless they're personality driven by some of the folks on this panel, right? Or you really push. So that, to me,
I agree about how we drive it.
Yeah, I don't mean to get cross, but I think it's important. I think if you think about some of the things that we can do, right? We can, if you think about lung cancer screening, and you can use the cloud, right? Democratize your ability to, all that's great, and it is. But how do we make sure that all this opportunity, to detect your lung cancer early, utilizing whatever you need, is able to be utilized without directly engaging with the community in an iterative fashion? I think we're going to be left with really nifty ideas, really cute and cool apps that don't always link to the folks that we need it to. But hopefully it'll change. That's where I think the challenge still bring the innovators to the community that you're trying to innovate to, and I guarantee you'll have different results.
No, I agree, and I want to just add my 2 cents onto this. And I think the explosion of telemedicine in the COVID era showed that the real barrier a lot of times was us. It wasn't that, people didn't, that the actual patients, and again, if we were to take a step back, this should always be about the patient. For some reason, we have a reversed system in terms of healthcare, which would never function in any other industry. But can you imagine if the airline industry was about the airline and could care less about the customer? It would be very interesting. But so it showed that, and I think, Mary, to your point, it just showed that patients were already there. We just had systems and clinical dynamics and attitudes and processes that we did not feel as a industry that we felt like expediting to meet the patient needs. And so I think to a large degree, that just showed us, I think, where people were versus where we are. And so that's going to be interesting. So I'm interested to, Caroline, I was going to ask you if you have any thoughts about where you would want us as a broader organization to be advocating for, and your thoughts around the patient voice. And then I want to come back to my next question. So if the group wants to start thinking about this, is you all, I'm a cardiologist, but you all deal with a diagnosis that when people hear those words, it's life-changing. You'll never be the same after you hear anything C related. And I want us to think about what are some of the non-traditional technological tools, or maybe tools that need to be developed, that could help patients think through their path from diagnosis, screening to, I think people get anxious even just showing up for screening, quite frankly, because they're afraid of what the actual, if something is found, that they might not be able to deal with it. But I want us to think through that. But Caroline, going back to where I was, do you see a role for advocacy and from an organizational standpoint, for us to articulate the voice of either patient or the voice of the concerned clinician within the deployment of technology to meet patient needs? Oh, Caroline, I'm not sure if you may, I can see you're speaking through your mask. I saw your mask literally moving.
Sorry, I didn't realize you were addressing that question to me.
Oh, I still can't hear you.
One here that represents the advocacy world, at least. Sorry, I wasn't using the mic. Okay. I was apologizing because I didn't realize the question was addressed to me, but I should have realized that since I'm the patient advocate on this. But I see the advocacy community as being a bit of a bridge between the healthcare community and the patients, because I think, for one thing, we have become a sort of a trusted resource to the patients. And I think that the healthcare community realizes that we're in it for all the right reasons. We're in it because we want to help patients, and we want to help amplify their voice and their concerns to the broader healthcare community. And I think when we're talking about vulnerable populations, there is a certain lack of trust on their part. And there's a long history of reasons for that lack of trust. So I believe that we understand that the first thing we have to do with vulnerable populations is to build trust. And so we've learned to do things like work with the faith community to help with messaging to underserved populations. And that's been a very important part of some of the programming we've done, in fact. But if we can serve as that bridge, then I think we're doing something that helps everybody, but most especially the patient.
Very well said. Thanks, Caroline. So going back to the panel, Caroline, was really interesting, I thought, when you started off by saying as you're being the patient advocate's voice. I think that's important. Going back to the panel, as you've seen in your either both clinical and non-clinical world, what are the kinds of tools that we should be leaning more into? It could even be something like social media in terms of, creating communities where people feel more engaged. It could be the kinds of, on a totally separate note, thinking through how we get clinicians more comfortable with ways in which they connect with their patients. Chris, I'm going to start with you to go in reverse order, but in terms of how we've been going, but interested in your thoughts about beyond what we've discussed so far, where do you see the future of things that should be on the horizon, even if they're not?
And so I think, people are doing really innovative things. As much as I was giving people a hard time about app development and making sure it's intuitive, people have done a really good job with using games and using technology to illustrate games on how to, whether you're talking about, let's take about lung cancer screening or any, you can have an animation, you can have a game, you can actually teach in so many different ways, right? So, right, I'm a Gen X person, so I get video games a little bit, right? That makes sense to me. And I think, when I've watched my, my children, how they interact with their phone, as you heard Garth say, it's very different. So I think taking a creative approach, and people have done this in medicine, developing different apps, using games and games to teach something and to teach advocacy. So I think one of the ways, that this could, we could really make some inroads there, and the future will be is in things like that. And then to make it kind of take it back a step, right? Even before we get to the next thing, just think about one of the things that we do as clinicians, because you talked a little bit about, when people come into your office and whether you're talking, one of the reasons I love talking about lung cancer screening is that then they don't have to see me in my main job, right? Which is giving chemo, right? Because that's a different conversation. And I love my outreach clinic, as I say to my to my outreach nurses, this day is a very different feel, right? And I'm sure Mary feels the same, right? You're in both spaces. It's a very different feel, working on prevention and saving lives in a different way. I would say, that, to me, one of the things that we could do that we don't do very well is use simple videos to illustrate things in complicated processes. So, for example, a lot of times all of us over talk, like I'm doing right now. We go too much. No, we don't. We don't speak like we would speak to our grandmother. We talk about it in a certain way, and we're usually kept from doing simple videos by some sort of process or organizational infrastructure. But what you have found is if you have, nursing is great at this, right? And we can do this. We can actually say, this is the process. This is your lung cancer screening process. This is what it's going to look like. You're going to go here. You're going to do this. You're going to do this. The technology works in this way. And then you're going to come back here, whether it's an animation, whether it's video, whether it's simple things that are talking to each other. Some of these things we could do right now. And then we can build more intuitive apps or games to really illustrate the points that we need, and then utilize our cloud technology to really empower folks the way we want. But I think some of this is just a matter of taking us out of the center and making sure that there is true diffusion of knowledge in the way that patients can incorporate it. And I think that can start with simple videos and describing what you're doing, moving up to animations and games, and taking it from there. So that's what I see.
Mary.
Yes, I can add to that. So I feel the same way. And I've struggled with this a bit because we used to engage our community by doing community health fairs within their community and at the churches, and COVID has changed that all. So now we're trying to reach back out to our navigators that work in the community to try to come up with solutions. Okay, we can't have live community health fairs. We can't meet at the churches. What can we do? And we're still trying to figure out that structure, even if it is just, touching base with the leaders of some of the communities, engaging with the leaders in the communities to kind of help us out to kind of keep their health, where so many times stress overtakes their lives that they can't even process what's going on with their health because they're dealing with other stressful situations, particularly living in, high poverty, high crime communities. But I think it's trying to figure out within the community what is the best for them, and then we adopt what is the best for them. And sometimes it has to be a multiple platforms that we work on, and that's okay, and to meet our patients. The other thing is the building that trust. I love my nodule clinic because the first time they come in to see me, it is the opportunity for me to build trust with them and actually going over their risk, and not just lung cancer risk. When we're doing thoracic imaging, we are looking at cardiac risk. We are looking at other risk factors or other things. I can see that coronary calcification, and I can talk to them. If they haven't had a primary care doctor, they may need to be on a statin, and I can connect them that day to a primary care doctor. So using every opportunity to connect with them and then meeting them where they are. And if I have to use a different type of app for this person, or I have a patient that has lung cancer, she's on a TKI, she can't come into the hospital because she has really bad arthritis. It's hard for her to get there. And so I meet her on a FaceTime, but she doesn't have a phone. It's her granddaughter that comes over and visits her on Friday afternoons. So we have our FaceTime visit on Friday afternoons just to see that she's doing okay and is not having a lot of side effects from the TKI therapy. So it's really just meeting our patients where we ever are. And sometimes it's not, I did a lot of global health work before doing the work I'm doing now. And sometimes it's not high tech, it's low tech. Whatever needs to be done. Sometimes it's not the high tech solutions that work, it's the low tech solutions that work.
Well said, well said. Dan?
Well, those are all great comments. And I suppose I could try to add a little bit in the context of the community that we serve. And they'll certainly appreciate, I would almost say this is almost framing it in a slightly different way, role for advocacy for vulnerable populations. What are some of the non-traditional technical tools? I would say the most traditional one, as everyone is well stated, is just the importance of developing trust with the patients. And that starts from day one. Interestingly, in a lot of this is low tech. I mean, so the model in the native communities on the reservations is they employ what are called CHRs, community health representatives, and they are lay people. Some of them have an LPN degree, most are high school degrees, but they're the ones who are out there transporting the patients. They look to them immediately for their healthcare needs. They can't prescribe medications, but they can connect them with the providers. So they're the bridge to their community. Another part that's unique out here is the traditional healers, the spiritual, the medicine men, and in fact, in our current palliative care grant, which interestingly is with Katrina Armstrong at MGH. So I know more people now from Boston than I've never known. So we keep getting smarter the more collaborations we have with you folks. But they've been, so there's an example with Katrina Armstrong's palliative care program where she's the co-PI in this project. But we are taking what you folks have developed and modifying that for the community. So other things that we've done as part of that so our palliative care project, what's palliation? That word doesn't exist in the American Indian language. That means you're going to die. So we have reframed that with our, so the first part of this grant is just going out and doing talking circles that range from community, they're all American Indian, but it ranges from cancer survivors to patients of, and I know a lot of these folks, I know to track them down, the spiritual leaders, but what they came up with is the definition of palliation for them is going to be living well with chronic disease, not turning it into a death sentence. And so, bringing it back to the LDCT topic here, and I know there's controversy about this, but there would be high value for us to bring an LDCT unit to these communities. And we've done this with screening mammography, because if one of my staff is listening on right now, Michelle Sargent, she leads the program. She's my right-hand person. We can get people for their mammograms. We can get them for LDCTs. It is a challenge bringing them to Rapid City when it's 2 hours away. So quick story how this works. And these are extenuating circumstances, but what we've now set up is we have a form that all the primary care provider has to do is fill up for an order. They'll send it to our staff. We can plug them into one of the LDCT sites. Our program pays for it because for a variety of reasons, there's some inertia going on with life and limb. So there's this thing in Rapid City called LNI, or the Lakota National Invitational. It's a huge basketball tournament, but it's also a cultural event. I probably will get condemned for doing this, but I signed 200 blank orders. They started doing community events, and I said, I'll write the order, get them set up. And we picked up a couple of early nodules, but our staff has been just phenomenal in adjusting to the community needs and what it takes. And I'm sure the IHS docs sometimes get a little irritated, but we're at the end of the day, we're trying to help them. And like you, trying to get them screened is a much different day as opposed to treating the bone, brain, and liver met clinic.
Daniel, a lot of folks may not be familiar with just how challenging your practice is. It's layered with so many different challenges, both the long historical disenfranchisement and lack of kind of paying attention to treaties that's happened within IHS and Native Americans who are on the reservation, off the reservation. And so it's an extremely complicated healthcare system to just deliver an aspirin, much less what you're doing in terms of treating kind of advanced oncologic diseases. I can't imagine how that is. I just know that from my brief experience working with Native American communities is the challenges that those very strong individuals have faced is just real and so deep and historic. So a lot. I think you could probably give your own kind of keynote lecture and full days of activities describing various stories about how you've been uniquely successful. Okay, we need to start thinking about wrapping up, but I wanted to kind of think through how we kind of bring all of this together. And I thought that one way would be having each of you. We talked about the kind of the patient. We talked about challenges and benefits, and I wonder if each of you could give your one big picture a thing that you would like to see happen. And this is as big picture in terms of national scale or policy that you believe would most allow us to advance the issue around getting equitable access to all the various technological solutions that could improve patient outcomes. If I was going to answer that question first, because I think I'm not going to be able to necessarily get the chance to speak this long again in the next 7 minutes, is I think broadband access is probably the one thing I would advocate for that I think could help build the backbone of improving patient lives through technology. But I wanted to open up quickly to the panel over the next 5 or so minutes. Maybe Mary, start with you, then maybe Chris, and then end with that.
Yeah, so I would agree. My big takeaway would be policies need to be equitable to everybody, and our care needs to be equitable. If more patients, certain types of patients, or those living in low socioeconomic communities need more resources, they need to get more resources. And I agree that, and we have to treat the patient, not the disease. We need to see the whole patient and what is driving their disease, because treating the underlying issues sometimes will prevent the bigger issues down the road. And I agree, the broadband would be great for expanding technology so we can reach it. We need to have options. We need to have options to be able to treat our patients wherever they are.
Sorry,
Chris.
that's next. I was just thinking about what Mary was saying. I was lost in thought there for a second. I think, you asked for one thing, which is always hard, right? Because we always we'll be like politicians and add 14 things in there because it makes more sense. But if I was just going to pick one thing, and policies are armed to do it on, you have to align your outcomes that you want with the incentives. And we can't continue to have this type of work be done through the cult of personality, meaning on the sweat equity of people who are driven to do this. Because eventually we all do other things, or the other things happen. This has to be aligned, and you have to want it. And I say that hospitals, society, like you have to want it, because that's where they say you vote with your feet. You vote with your money, and you vote with accountability. And we can sit and talk about this as a, hey, let's think about, lung cancer screening and how we're going to use technology. And I think that that's a great conceptual conversation. But the truth is, you have to align the incentives to the outcomes that you want to get the impact, because that's where whether you're a policymaker, whether you're a healthcare executive, that's when we know that you care, because you've actually driven it so that the incentives make it happen.
Well said. Thanks, Chris. Daniel?
I feel like I'm giving answers in a group of titans, so I'm the little guy out here, okay? So where I live, the big issue is poverty. That is the overarching issue. I mean, this is an extremely impoverished nation that's been broke. The history out here, I'll try to be quick, is really interesting, from Red Cloud to Crazy Horse, Black Elk. I mean, and they have a lot of vision. And there's one movement going on out here which gives me a lot of hope. This place is called Thunder Valley. If you ever get a chance to Google on it, but it's a platform for economic development, and it's a grassroots effort, and they're building a community in Pine Ridge. They're providing jobs, they're educating the folks. I mean, to me, big picture stuff would be addressing poverty. And as one of my Native friends says, we don't want necessarily, how does he say it? We want equal access. We want my kids to have the same opportunities that your kids in Rapid City have, and that's fair. In the healthcare world, I mean, IHS is dramatically underfunded compared to what the average U.S. citizen receives. There's a thing called 638. It's a 638 model where instead of IHS taking the tribes that take over healthcare, and that's starting to happen in Rapid City. So my Pollyannic vision would be addressing poverty, because I think cancer, just like cardiovascular disease, is one of many symptoms. Yes, it's a challenging position where we're at, but I'm also grateful because the rewards have been tremendous. I mean, the relationships I've had, the stories I've been told are crazy. I mean, I have this picture of a Native American guy who's a friend of mine. He's sitting in my office and he's kind of looking at me, and what I often tell people is, Larry's telling me, hey, Dan, I think that's a bad idea. I said, Larry, that's probably right. So I would say addressing poverty would be the big one, trying to improve. Funding it all takes money. And to me, it's very grateful to be in a panel, people like you, because I've never met you before. And we've been able to succeed out here through collaboration. So I see you as my next level of collaborators, more people from Boston and others.
Perfect, absolutely perfect ending, Daniel. Spoken like a true leader. Thank you for that. So we were actually literally just hit our time with a landing that I could not have planned better by Daniel. Caroline, do you want to close us out?
I would love to. I think am I on? So I would love to. I'd like to first have the opportunity to thank all of you. This was a wonderfully engaging and rich discussion, and it's really the vision we had when we first kind of conceived of this session. So we really appreciate everyone's time and thoughtful presentations, the amount of time you put into preparing, and Garth and Chris, the amount of time you spent on the phone with us as we were organizing everything. All of you, Dan, Mary, you just did a great job. So I couldn't really be more pleased with the outcome of this session. And I think it's one that we needed, and we need to continue it. And then I'd like to say a final remark, and that is to thank Amgen for its sponsorship of this session. That company has a big commitment to the medically underserved, to addressing disparities. And when we asked them if they'd like to support this session, they were really happy to do it and made it happen. So thank you, Amgen, and thank you all, panelists, Garth, Chris, Mary, Dan. Really appreciate your time.
Thank you.
Thank you very much.
Thank you.
Thank you, Caroline. And I think we're over.